Welcome to today's webinar brought to you by Grassroots Health. Thank you for attending this morning. I'd like to start by reading off a quote from one of Dr. Vin Tangpricha's recent publications. People with cystic fibrosis are at risk of vitamin D deficiency due to malabsorption of fat-soluble vitamins. Ample evidence confirms that individuals with CF have abnormal bone metabolism. There is concern that vitamin D deficiency may contribute to other comorbidities. Today we welcome Dr. Vin Tangpricha, MD, Ph.D. He is an associate professor of medicine at the Emory University School of Medicine, as well as the director of adult endocrinology at the Emory Cystic Fibrosis Center, and the co-chair of the Clinical Practice Guidelines Committee for the CF Foundation. We are excited to have Dr. Tangpricha present present on the topic of improving clinical outcomes of cystic fibrosis with vitamin D. And with that, I would like to welcome Dr. Tangpricha. Thank you so much for your time today. The floor is all yours.
Thank you very much for inviting me to give this webinar. This is my first webinar for this group. And today I'm going to talk about vitamin D and cystic fibrosis. It's a very important issue in the CF community. Let me see, I'll advance my slides here. And so I just basically have two learning objectives for everyone. One is to recognize the important functions of vitamin D for health in patients with cystic fibrosis. And then the other objective is just to go over the CF Foundation guidelines that were released a couple years ago to improve vitamin D health in CF patients. So we're going to walk through vitamin D metabolism. I think this group has already received a lot of information about how vitamin D works, but we'll review that again. We'll discuss prevalence of vitamin D deficiency in the CF community, causes of vitamin D deficiency, again review the CF Foundation guidelines, and discuss how to replete vitamin D status in CF patients. And at the end, if we have time, discuss future directions. So, here we go. So I think this group already knows that there's two forms of vitamin D. Vitamin D3, known as cholecalciferol, is the vitamin D made in your skin or obtained from fatty fish. And vitamin D2, known as ergocalciferol, is obtained from irradiated fungi or yeast. There's a minor difference between the two compounds. There's a double bond and methyl group on the vitamin D2. Both forms of vitamin D are used in supplements and used to fortify foods, but only vitamin D3 is made in skin. And there's some recent data suggesting that vitamin D3 may be more bioavailable, especially in the CF population. I'll share some slides with you regarding that data. Again, this is review. There's a compound in skin called 7-dehydrocholesterol that upon exposure to UV light breaks the beta ring or the second ring of the vitamin D compound to form vitamin D3, and the same exact reaction occurs in fungi or yeast. There's a compound called ergosterol that upon exposure to UV light breaks the second ring to form ergocalciferol. The vitamin D that's made in the skin or obtained in the diet circulates in the body and goes to the liver and is hydroxylated in the 25 position to form 25-hydroxy vitamin D. And as many people know, that this is the major circulating form of vitamin D. This is the one you measure to determine someone's vitamin D status. The 25-hydroxy vitamin D then circulates to the kidney and is hydroxylated in the 1 position to form 125-dihydroxy vitamin D, and that's considered the hormonal or active form of vitamin D. It used to be thought that only the kidney could activate vitamin D, but now we know that many other tissues activate vitamin D, and so that's why vitamin D may have other important functions throughout the body. The classic function for vitamin D is to improve calcium absorption in the intestine for proper mineralization of bone, to maintain normal serum calcium levels. If you don't have enough vitamin D in children, you develop rickets, and this is an example of a child with cystic fibrosis who has developed rickets. In adults, you develop osteomalacia, and this could lead to vertebral compression. And this is an example of a patient with cystic fibrosis who has severe osteomalacia. You can see that the spine is already curved and suffers from compression fractures. That's really important for cystic fibrosis because the chest does not have as much, cannot fully expand, and so there's not enough volume for the chest to take a full breath in CF. It's been known for quite some time that vitamin D deficiency is associated with poor bone health in CF. This is data from 1998 showing that patients with very low vitamin D status, less than 10 nanograms per ml, or the conversion is 25 nanomole per liter, had lower bone density, the lumbar spine in both men and women with CF, as well as total hip bone density was much lower in those CF patients with low vitamin D status. Let's see here. This slide shows, again, the relationship between vitamin D status and bone health. On the y-axis is the vitamin D concentration, the 25-hydroxy vitamin D, and on the x-axis is the z-score in the femoral neck and lumbar spine. The z-score also corrects for age, so that's why it's a little bit better than the t-score. And you can see here there's a positive relationship between vitamin D status and bone mineral density, meaning the higher your vitamin D status, your higher your bone density at the femoral neck and lumbar spine. We know in cystic fibrosis, like many other diseases, the vitamin D status does fluctuate by season. It's usually lowest in the winter time and highest in the summer or fall. In the CF population, we also know that there's a strong latitudinal component. This slide looks at the prevalence of vitamin D deficiency by latitude, and you can see 4 different CF centers around North America. There's 100% vitamin D deficiency in Toronto, and as you move south in Philadelphia, 90% vitamin D deficient in CF patients, 81% in Baltimore, vitamin D deficiency in CF patients, and in our center, 76% of our CF patients had vitamin D deficiency. If you want to compare against healthy individuals, the yellow bar is the NHANES data. That's a sample of healthy adults in the United States, and this is data comparing at the end of summertime the vitamin D status, and you can see here in blue are 4 different CF centers. Compared to healthy adults, CF patients still have a lower vitamin D status at the same season. One of the reasons that CF patients have vitamin D deficiency is they suffer from chronic malabsorption. For those who are not familiar with cystic fibrosis, it's a multi-organ disease, mostly affects the lung and pancreas, and because it affects the pancreas, CF patients aren't able to make the enzymes to effectively absorb fat-soluble vitamins. And this was a study showing in the solid line, a healthy individual, and the absorption of vitamin D, and the dotted line are the means of patients with cystic fibrosis, and you can see that CF patients only absorb half the amount of vitamin D compared to healthy individuals. The figure on the right side is just a summary of the entire groups. The healthy group absorbed twice as much as the CF group. There are many other factors that cause low vitamin D status in CF. We mentioned the fat malabsorption. There are probably issues with not getting not enough sunlight exposure. We discussed the season latitudinal effect. CF patients are probably not eating enough vitamin D food, vitamin D fortified food, probably not taking enough supplements. CF patients are often prescribed pancreatic enzymes, and they may not be adherent to their enzyme use. In terms of factors that influence the 25-hydroxy vitamin D status, CF patients have very low body mass index, so have very little adiposity, so there may be less fat storage of vitamin D. They may be taking medications that increase the catabolism, circulating 25D, and they may also have very low vitamin D binding protein. So all these together are explanations why CF patients are uniquely at risk for vitamin D deficiency. So because of these issues in vitamin D, the CF Foundation put together a multi-specialty group of different professions to formulate vitamin D guidelines. I was fortunate to chair the committee with Drew C. Borowitz from University of Buffalo. The committee was comprised of pulmonologists, nutritionists, nurses, social workers, and we're really charged to address this issue with vitamin D deficiency in the CF population. And so this is the composition of the committee, and basically we wanted to have very strong evidence-based guidelines to help clinicians treat vitamin D deficiency in CF patients. So some of the key topics of interest were: how do we address vitamin D status? What should the target 25-hydroxyvitamin D be? What type of vitamin D should we use? How should we treat different individuals with CF at different ages? And was there a role for UV lamps? And so these were some of the main general topics that we tried to address. So our committee posed questions to the evidence-based review team, and we asked them to look up literature in terms of how to assess vitamin D status in CF patients and different target goals and different levels of supplementation. And so a group of evidence-based researchers at Johns Hopkins looked at the data in the literature and focused on patients with cystic fibrosis. And so this is how the data collection was performed. They reviewed large electronic databases, Medline, Central, Embase. They looked at 675 manuscripts. They screened them to make sure they met the questions that the committee had posed. They looked at other inclusions, such as making sure it was focused on cystic fibrosis, and were very high quality studies. And at the end, we end up with 33 eligible studies that were high quality to make these evidence-based recommendations. And so the first question was, how should we address vitamin D in CF patients? And so our committee recommended that that the 25-hydroxyvitamin D be used to determine vitamin D status. And that's no different from the general healthy or chronic disease population. Number one, we recommend against using the 125 dihydroxyvitamin D to assess vitamin D status, and we recommend it against other surrogate markers of vitamin D, such as PTH, osteocalcin, alkaline phosphatase, and other markers that might be used to determine vitamin D status. We just felt that we use the word routine. There may be some occasion to measure parathyroid hormone, but we wanted clinicians to focus on measuring the 25-hydroxyvitamin D. What should the target 25-hydroxyvitamin D be? And we recommended that CF patients have a 25-hydroxyvitamin D target of greater than 30 nanograms per ml, and that's pretty much similar to the Endocrine Society guidelines for adults. If the levels were low, our first step was to make sure patients were taking the vitamin D that was prescribed. When should we measure vitamin D levels? In the past, the CF Foundation recommended that levels be measured in the fall, but we felt as a committee that that may falsely lead to the impression that vitamin D status was adequate in CF patients because that would be done at the peak, and we believe that measuring the 25D at the nadir, which would be at the end of wintertime, would give the best information. If your 25D was very good at the end of winter, you'd feel pretty good that your patient's 25D status was good all year round. When should we recheck vitamin D levels after a change in therapy? And based on the evidence, and given that the 25-hydroxyvitamin D has a half-life of 2 to 3 weeks, we recommend remeasuring it 3 months after the dose of vitamin D has been changed. When should we supplement patients, and what should we use to supplement patients? We recommended using the vitamin D3 or cholecalciferol to target normal vitamin D status. The previous guidelines had mentioned use of ergocalciferol, but we felt there was strong enough evidence to recommend chole over ergocalciferol. Okay. This is This is a slide summarizing some of the data looking at ergo versus cholecalciferol, and you can see here there are about 4 studies that use ergocalciferol, and there was 1 study that used cholecalciferol, and you can see only about half the patients who received ergocalciferol received optimal vitamin D status, whereas a study that used cholecalciferol achieved optimal vitamin D status. 100% of them achieved optimal vitamin D status. The next slide is going to review the Kazai study in more detail. This was a randomized controlled trial where we took adults with cystic fibrosis, randomized them to ergocalciferol, cholecalciferol, or UV light therapy to better define which therapy was the best for treatment of vitamin D status and CF. The people who took the vitamin D took 50,000 units once a week for 12 weeks. The UV light group used a lamp between 3 to 10 minutes, depending on skin type, 5 times a week. These are the results. You can see that those who were assigned to the vitamin D3 or cholecalciferol group on the left side of the screen had the best response. The ergocalciferol had the second best response, and the UV light group did not respond as well. That's likely due to the very low adherence to the light therapy. Roughly half of the participants did not use it as prescribed. What's interesting is that the individuals who were given the ergocalciferol in the dark bars had a decline in the 25-hydroxyvitamin D3, which is the endogenously produced vitamin D, and that we believe is why the ergocalciferol treatment did not work as well, because the endogenously produced vitamin D was being was being catabolized quicker. And this was confirmed by another group. This is a group from Hopkins where they gave patients with CF ergocalciferol. You can see here on the left side, you can see there was a modest increase in the total 25-hydroxyvitamin D. As expected, there was an increase in the 25-hydroxyvitamin D2, but again, similar to our results, there was the decline in the 25-hydroxyvitamin D3, indicating that there may be some increased catabolism of vitamin D3 in response to ergocalciferol. Looks like I only have about 5 minutes, but I'll go quickly through the rest of my slides here. Let's see, there you go. The next question was, what dosing schedule should we use in our patients? And this was to address whether or not we should give patients daily or weekly. and our committee felt that it didn't matter. Daily or weekly would be fine to give in CF patients as long as their 25-hydroxyvitamin D was above 30 nanograms per ml. Are there other forms of vitamin D that should be used, such as calcitriol, doxycalciferol? And our committee recommended only using these forms of vitamin D if a patient had very difficult to treat vitamin D deficiency, and only with consultation with an expert in vitamin D therapy. Okay. This is the table from the guidelines that were um, given to the clinicians, and you can see here this was a very user-friendly table. We recommended all patients start off with some dosing of vitamin D, and most of these doses of vitamin D could be already found in their multivitamin that most CF patients are already taking. If their vitamin D status was low, you would go to step 1, which would be a near doubling of the vitamin D intake. If the vitamin D status was still low, we would increase to step 2 and titrate to the maximum dose. And if the levels were still low, you'd get to step 3 and refer. And this was a major improvement from the previous guidelines because there's a stepwise increase in the dosing of vitamin D. The previous guidelines did not give much guidance of what to do after there was a dose titration. So I think these guidelines will work much more effectively for patients with CF. If an infant has very low vitamin D status, age less than 1, we recommend that these patients be referred urgently to a specialist in vitamin D. We didn't think clinicians should be titrating dose because we were concerned about rickets. Next slide. In terms of UV light, we were not able to recommend for or against the light therapy because we felt there wasn't enough data. There were only a few studies that used UV light therapy in patients with CF. This is one of the studies we completed. It was about 5 patients showing that there was a significant increase in vitamin D status. But this was a study done over about 12 weeks in. Patients only used the light therapy for twice a week. There was another study in Sweden where they gave 9 patients full body irradiation, and again it was very promising that patients had a significant improvement in their vitamin D status. But I think because the committee felt the ends from these studies are very small, they could not recommend for or against these therapies. So in summary, vitamin D insufficiency or deficiency is common in patients with cystic fibrosis. There are many reasons for low vitamin D status in patients with CF. We believe the CF Foundation guidelines will provide clinicians very strong evidence-based guidelines to improve vitamin D status in CF. As in other populations, we believe a 30 nanogram per ml cutoff is optimal for CF, for vitamin D status in patients with CF. And in the future, we believe that the effects of vitamin D may go beyond bone. There was not evidence at the time to look at other conditions that are important in CF, such as infections, lung function. But we're hoping in the next few years we'll get some of that data and hopefully help us guide better the target 25D level in patients with CF. And that ends my talk, and I don't know if I have time for a couple questions, but I might have gone over a little bit.
No, I think you're doing great. And thanks again for that great presentation and for all the detail. We did have a few questions that were submitted that we'll go through.
Okay.
First, I did want to touch on this chart. It's on the homepage at grassrootshealth.net. And for those of you who are listening who would like to improve your vitamin D status, I mean, one of the most frequent questions we get is how much vitamin D should I take? And this graph you might find helpful. You can basically see where you currently are at and where you would like to be, and then find out what your daily dose of vitamin D could be to help improve your level and get them to where you want them to go. Again, that's on our homepage at grassrootshealth.net. And on to our questions. You did touch on these briefly in your presentation, but just to go through and again, when you're answering these questions, if you could also put that converted rate of N mole per liter, that would be very helpful.
Okay.
Question number 1, how much is the right dose for a child of 14 years?
So I'm assuming this is a child with cystic fibrosis is the question.
I would assume, yeah.
Yeah. So the guidelines recommend a child that's 14 years old be on at least 800 to 2,000 units of vitamin D. So if the 25 hydroxy vitamin D is above 30 or 75 nanomole per liter at the end of winter time, then that would be the right dose. If the level was still low, then the CF Foundation guidelines will recommend nearly doubling the dose. So that would be between 1,600 to 6,000 units of vitamin D. And again, rechecking in 3 months. If the level was good at that point, then that would be the right dose. So I think um, the the point was that we're really going by the level of 25D because the CF pancreas has difficulty absorbing vitamin D, and we can't recommend the same amount for everyone because everyone's the CF pancreas has different. Um, some patients have less severe pancreatic insufficiency than others, so we really want to target a 25 hydroxyvitamin that's optimal.
Right, and it's per individual is what I'm hearing you
Yes.
say.
Yes.
Okay, and for those of you who are listening right now, this webinar is recorded and it will be posted on our website. And the graph that you showed, Dr. Tangpricha, would be a great one to refer to, I'm assuming,
Yes.
for other dosage questions according to age.
Yes.
Awesome. Okay, great. I see there's no more question number 2. So question 3, is vitamin D supplementation part of normal CF treatment?
So the answer is yes, because, as I mentioned, the patients don't absorb fat-soluble vitamins. Most CF patients are taking something called ADAC vitamins, which are all the fat-soluble vitamins. It's the ADAC is vitamin A, D, E, and K, and so most patients are on a minimum amount of vitamin supplementation. Now that might not be enough for in terms of vitamin D, so that's when the guidelines come in and recommend additional vitamin D on top of the multivitamin.
Okay, so when somebody's going to see their doctor and they find out that they have CF, do they have to ask their doctor if they follow certain guidelines, the CF Foundation guidelines, or is it just a part of normal routine standard of care?
It's usually normal routine standard of care. Most patients with CF will probably be going to a CF care center, and so most of the care centers will be following standard practice guidelines.
Okay, great, thank you. Question 4, how does low vitamin D affect CF carriers? So perhaps somebody hasn't been diagnosed with it, but it's in their genes.
It probably well, I guess low vitamin D affects everyone, not just CF carriers. But I guess the question may be, are CF carriers at risk for low vitamin D? I'm assuming. So if that's the question, probably the CF carrier status would not result in fat soluble vitamin malabsorption. Um, there may be other reasons to make sure you take enough vitamin D. Everyone should take vitamin D for health.
Right,
I think that's
right.
yeah.
Oh, okay, great. Our last question, question 5. Do you think adequate vitamin D3 during pregnancy could prevent CF?
Probably not. CF is um, a specific there are many mutations that cause CF, and so um, if if you have both parents that are carriers for CF, you probably couldn't prevent the mutation from being passed on to the child. So, unfortunately, vitamin D would not be able to prevent CF. We're hoping that maybe we'll prevent the complications of some of the complications of CF, but it wouldn't prevent a child from getting CF.
Okay, thank you so much. And do you have anything else that you would like to add before we close this presentation?
I would just say to get a copy of the CF Foundation guidelines if you're interested in learning more about what to do. I think they're a very useful set of guidelines, and the feedback has been very good from the guidelines, and I think they're working very well. So if people are interested, if you don't have access, I can send it to you, or people can contact me for a copy of them.
Okay, so there's nowhere online that people can go to access those guidelines?
I think they may be posted on the CF Foundation website. I know it's published in the Journal of Clinical Endocrinology and Metabolism. Um, but if people are having trouble finding them, um, I'm sure I can get a copy to them.
Great. Okay, and we can also link to them from this webinar once we
Yes.
have it posted. Well, that was great. Thank you so much again for your time. And thank you to the audience as well for attending and submitting your questions. I'd like to ask you to also tune in next week for our webinar. We're continuing some of our recorded interviews from the Linus Pauling Institute's 2013 Diet and Optimum Health Conference. Next week, we will be focusing on two different topics. One with Dr. Thomas Byrne on vitamin D in the brain, and the other with Dr. Kelton Tremelin on vitamin D and fertility. Again, you can sign up for our webinars at grassrootshealth.net/webinar sign up. You can also find a link directly on our homepage. And if you haven't already, we urge you to become a sponsor of our webinars by visiting our website and ordering your vitamin D test kit to join the D-Action program. And in doing so, you will become one of our webinar sponsors. Thank you again, everyone, for your time and participation, and we hope to see you next week.